Good evening, everyone. This is Metropolitan Nathanael, and I welcome you to our conversation this evening. I'm joined by a number of physicians and law enforcement experts. We thought it would be important for us to have a dialogue together, and through this dialogue to help our people understand what exactly is happening with COVID-19, for you all to hear from experts who are managing and caring for us and protecting us firsthand. Recently in the Metropolis, there was some information circulating that suddenly the coronavirus has mutated, that it no longer is possible for us to get sick by breathing something in the air, and so therefore there was a push to have our churches open and celebrate the services during Holy Week in the normal way. As many of you have seen already, the Holy Eparchial Synod has made a decision that we would not celebrate the services in the conventional way, but that we would continue celebrating behind closed doors. So I'm joined tonight by a number of physicians and and law enforcement experts. I don't know if we would call the law enforcement experts, but by members of the law enforcement, and I'd give them an opportunity at this time to introduce themselves. Chris?
Hi, I'm Dr. Chris Costas. I'm a pediatrician, an internist, and an infectious disease specialist. I've been in practice for 30 years. Right now I'm working at Howard Brown Health, doing mostly care with HIV infected individuals.
Jim?
Yes, I'm a professor of medicine and emergency medicine at Northwestern, and I'm an emergency physician. I work in the emergency department. I'm also an epidemiologist, and I'm at Northwestern University.
Thank you, Jim. Regina?
Hi, my name is Regina Stein. I'm a professor at Northwestern University in the Department of Hematology and Oncology. Very appreciative, very thankful to be with you this evening. My family lives outside Athens, and I'm also very grateful that everyone is doing okay, and a lot of the strict measures that were put in place were put in place. If I can say in Greek, εύχομαι να είμαστε όλοι καλά με τον δύσκολο καιρό τώρα.
Really ωραία. Where's Angelo?
I am Angelo Costas. I'm a primary care physician and internist at Northwestern University as well.
Deputy Chief?
Good evening, everybody. Steve Georges, Deputy Chief with the Chicago Police Department. Been with the Police Department for 28 years of service, and I'm presently tasked with overseeing all the safety and security surrounding the McCormick Place COVID alternate care facility that's being stood up this week.
Hopefully we don't have to use it, but...
Exactly.
Dr. Chiampas, George?
Good evening, everyone, and thank you very much for the opportunity. I'm George Chiampas. I'm an emergency medicine and sports medicine physician at Northwestern. I work as the Chief Medical Officer for United States Soccer, Medical Director for the Bank of America Chicago Marathon, Team Physician with the Chicago Blackhawks, and also serve as the EMS Medical Director for the Chicago Police Department as a liaison for the medical community. So thanks for having us.
Thank you, everyone. I appreciate you dedicating your time to this. I know you're on the front lines and you have important work that you're doing. So this is, I would say, as important, because hopefully this will prevent people from getting sick, so you won't have to see them, care for them, or bring them to the hospital. Why don't we begin with kind of some basic information about the coronavirus, the new coronavirus, or COVID-19, the disease. Dr. Costas, can you just tell us what is COVID-19? You know, is it really lethal? People are still questioning if this is lethal and if it really matters that we're dealing with this kind of virus now, and maybe we should be treating it as the regular flu. You know, how do we know if someone is infectious, and you know how long this someone remain infectious?
So the viruses get basically classified into RNA viruses and DNA viruses, and this is an RNA virus. It's related to the SARS virus that affected the world from the Far East. It's also somewhat related to the Middle East coronavirus, which had a very, very high fatality rate of almost 50% of people who were infected. This virus enters the body through contact with the nose, the eyes, or the mouth. It's spread primarily by droplets, which is just spittle, or just when we breathe out a certain amount of droplets. It probably can travel 3 to 5 feet from the body if someone coughs farther. Breathing that in would get somebody infected in a rate probably of if 3 people for every 1 person that's infected. The knowledge about the infectivity is changing very much as we get more data in about how many people are infected. It was thought that you were infectious primarily right when you had fever. The disease produces a fever. This lasts several days. It is usually accompanied with a cough, not usually a sore throat or runny nose, but a cough. It can be accompanied by diarrhea. The disease then, after about 7 to 10 days, descends from the upper respiratory tract, the nose, the throat, down into the lungs, and can cause a very severe pneumonia. The infectivity of the illness is not well known, but the recommendations are that you should isolate yourself for at least 14 days after you have a fever. If you're a healthcare worker, you can return to work if you're healthy for 7 days or 3 days after you feel fine, and that you should wear a mask thereafter for at least 2 weeks. It appears as though people without any symptoms whatsoever can transmit the disease, and that's led to the recommendation that everybody wear masks because no one really knows whether they can transmit it or not. The virus can live on surfaces, and I think it's variable as to how long people think it can last. Some people can say it can last up to 3 days. Some people say less. We don't really know, but it certainly can live on surfaces, and therefore we worry about people coughing and then somebody else coming up and touching, let's say, an escalator railing or a handrail to get up the stairs after someone's coughed, or wipe their nose and then touch the common place where everybody touches. This is why we have recommended masks to keep people from spreading the disease to other people. We've recommended hand washing. There are some studies out of China that washing your hands every 20 minutes really did reduce infection rates. Is that, I think the other doctors can sort of add, but I think that that's sort of a basic. Now, in terms of its lethalness, it's very difficult to determine the lethality of something without knowing the total population that has it and then how many people died. But Dr. Kyriacou is an epidemiologist and might be able to say some things, but I don't think we have a good, we call it a denominator, everybody who's infected, because we have not got enough tests to figure that out. But certainly the disease is very aggressive in people over the age of 60. And if you're looking at the daily counts of how many people die, most of the deaths are seen in people 70 or 60 and above. There have been very few deaths in the pediatric population. There was one infant that died, but that child had been born at 22 weeks of gestation. So that was a extreme premature that had lung disease. But we do not consider this to be that lethal a disease to children. It does not appear to be lethal to fetuses and pregnant women, although we don't want children to get this. And so some of the recommendations for pregnancy are that you be screened at the time of delivery, and many hospitals are performing cesarean sections in anticipation of not spreading the disease to the infant. Part of that is because delivery itself creates a lot of mist, and the mist transmits the virus all over the room and can definitely infect the baby after the baby comes out. So there are some changes in terms of what's recommended for pregnancy and delivery.
So, doctor, you mentioned that we don't know how many people have it. There are asymptomatic individuals. So where are we right now with developing a test or enough tests for people to be tested? Where are we with a vaccine, and kind of, are there any medications out there that could help treat COVID-19 that we know that actually work?
So the first question is testing. What we have available now is a test that looks for the genetic material of the virus. This is obtained by putting a swab through someone's nose to the back of their throat, twisting it around, pulling it out. That test, there's a rapid test that can take an hour to come back. There's other tests that can take up to a day or two to come back. The state's taking about 7 days to get results back. These tests have not been very, very well validated, and they may have an error rate somewhere between 20 and 30%. Certainly, the closer you get the swab to the fever, the greater the chance that you're going to get a positive test. Once you're about 7 or 8 days out from the fever, the test, its ability to detect the virus decreases. There is a blood test also to see whether you have the disease and whether you have had it recently or not. These tests are coming out of Korea. They're coming out of several different countries. They have not been well validated. I believe one of them has been approved by the FDA so far, but most of them have not been approved yet. But we believe that those tests should be coming in the next week or two. In terms of treatment, there is some studies of looking at an anti-malaria drug, which is a parasite called hydroxychloroquine, coupled with an antibiotic. Now, remember, viruses enter into a human cell and then take it over and use the cell in order to replicate and to copy themselves and to propagate themselves. And so something that is an antibiotic works against bacteria and kills bacteria, which never really co-opt the body to stay alive. And a virus is very, very different than a parasite, but these drugs, for some reason, manipulate the immune system slightly and can manipulate how the virus enters the cell, and they have theoretical possibilities of working. They are at the moment being used in people on ventilators because we have nothing else to use. The third option is that in people who have had the disease, they make antibodies. Now, some antibodies neutralize an infection. They hold it at bay until the immune system can kill it. And a lot of other antibodies are made, but they don't really have that ability to neutralize. But it appears as though that if we take blood out of someone, and Dr. Stein might be able to talk about this more because she uses this technology more than the rest of us. We filter out the blood, we take out the liquid portion that is not blood, and we can concentrate antibodies and then give them back to a person who's infected. And the neutralizing antibody can bind to the virus and stop the infection from being as severe. But these are measures that we're using very late in the process when someone's on a ventilator and someone has very advanced disease. Or they're admitted to the hospital and they're requiring oxygen and they're requiring therapy. That is beyond just watching. The majority of people will have a disease that is a mild flu-like illness. Some people will develop pneumonias, which will pass with just time itself. Some people will develop a bacterial pneumonia on top of the viral pneumonia, and we need to give them antibiotics. And then a small minority maybe, well, it looks like the death rates are quite low here in Chicago, but in New York, much higher, and in Louisiana, higher. But in a very small number of people, the disease will become so severe that they need to be assisted in terms of breathing with machines and to be put on these sorts of experimental therapies.
Well, I mean, I have to say I've been watching the news throughout the day, and we hear a lot of different things about how the virus works, potential treatments and so forth. And I don't know that anyone can really truly understand the complexity of it through a 2-minute soundbite on television. And what you've shown us by your summary of this is that the best option we have, the best possibility is to prevent the spread of the disease. And so I'd like to ask maybe you and the deputy chief to talk to us a little bit about the difference between what is the difference between social distancing, staying away from each other and so forth, and, the 6-foot rule and stay-at-home orders. Because I think both of those expressions are being used. I don't know how we should understand social distancing and versus stay-at-home orders that the state issues. So one, from a law enforcement and from a medical perspective.
Let me start. Because of the nature of breathing and droplets, a 6-foot distance between people who are not coughing and are not sneezing probably decreases your chance of contracting this virus. On the other hand, if somebody coughs, walks away, and you touch the surface they just coughed on and touch your eyes, you will get the illness probably. And so the difference is social distancing is that if somebody's walking down the street, you should go to the other side of the sidewalk so that you're away from them. But that doesn't mean that they haven't touched a doorknob to a restaurant that you're going in to pick up food from, or that they haven't coughed like 5 minutes before you or a moment before you turned a corner. And so therefore, social distancing definitely decreases transmission, as does hand washing, as does wearing a mask to protect people from you. But it doesn't nearly work as well as being home, washing your hands, and not having to be out where people might have coughed or people might have touched things. And therefore, it's very wise for people to stay in their own homes and not go out unless absolutely necessary. And that would be the difference between a stay-at-home order and a social distancing order. Now, social distancing is something that is somewhat tolerable, but staying at home for months at a time, a lot of people don't have the impulse control to be able to do that. And therefore, I believe that that the police force and the city is trying to help encourage people to behave in a way that's safest for themselves and all of us.
So, Deputy Chief, have you seen gatherings? I know they talk about gatherings of no more than 10 people. Have you seen large gatherings outdoors, and have you had to break them up, or what has been your experience?
So I think if I could just start too by explaining that the many people don't realize that the health department and health officials, there's many laws on the books for this exact type of scenario to keep the public safe. And because, excuse me, they don't become used all the time, people know that they can't speed. People know, no turn on red, but they don't realize that when a public health order is given under these circumstances, it is a legal order of which you could be fined or physically arrested for violating, right? It happens once in 50, 60, 70 years maybe, so the public isn't used to it. And I think the public in the beginning didn't realize how important and the punishment that could come from it. From a police department perspective, we're doing our best. I believe we have issued citations. I don't know if we've physically arrested anybody for violation of the order, but I can tell you this past weekend, there were over 15 or 1,600 instances across the city where the police had to go in and give dispersal orders to break up groups of more than 10 people that were congregating. It's challenging. It's challenging for all of us, and it's exposing our first responders even more so, who make the decision every day to leave their home to go out and keep everybody safe. And instead of following the rules and doing what's asked of us, exposing them to more risk as well. And the reality is we may be exposed, and now we're dealing with public not following the rules, and we could be transmitting that virus as well. We know we're going to have a higher percentage of infection rate because of being out in the public and dealing with what we're dealing with.
Yeah, I mean, staying at home, my mother and I have been trying to do this for the past, 24, 25 days now, and it's tough. And because mom doesn't go out, she stays home basically all the time. And because I go out, we've actually, introduced social distancing within our own home. So she's like kind of watching TV on her own in one room. She has her own bedroom, she has her own bathroom. I have my own television, and whenever we use common spaces, we make sure we wipe it down. We try to talk to each other across the room rather than at the table, because I don't know if I have the disease and I'm asymptomatic, and given that my mother is over 80 years old, I worry if she gets sick, who's going to take care of her? So Dr. Kyriacou, tell us a little bit about this epidemic. How long, by the way, epidemiology was one of my worst classes. That and biostatistics, I didn't do too well in those classes at all. But tell us a little bit about, how long we think this epidemic will last, and when do we see the peak actually occurring, and then the decline. Everyone talks about flattening the curve and stuff, but what are you seeing out there? What is the model that you're looking at, say?
Right. So this is a difficult question to answer with any certain degree of certainty, because there's not. We've never seen an epidemic like this from coronavirus. We've seen epidemics from influenza, from other infectious diseases, but this large from coronavirus has not been seen before. We had the SARS epidemic, but that was basically contained very quickly with only a few hundred people, maybe a couple thousand, I think, actually got sick, and a few hundred that died. So, but what we can do is we can look at historical examples, and we can look at what's going on around the world. We can actually look at the different countries and see how they're doing with the epidemic and how long it's taken them to ramp up to the apex and then come back down to a reasonable lower number that can be taken care of with the health resources that we have. If you look at these different countries, they all have a little bit different characteristics in terms of how long it takes to ramp up and how high they are, and if they have a second wave. But in general, the epidemic goes from the initial upswing to kind of going down to the end. And there's only a few countries that have been able to do that so far. It looks like somewhere between 6 weeks to 2 months. So we're about 4 weeks into this, maybe around 4 weeks. And so I think we have at least another 3 to 4 weeks to go before we get down to a small, reasonable number of new cases. That's what we're looking for every day, is the number of new cases. Now that doesn't mean that we're not going to have severe cases that end up in the hospital or end up dying start to go down after you see the downslope of new cases, because those people that are new cases, they tend to become sick in a week or 10 days after, become really sick around that time. So this is going to be a drain on our health resources, healthcare resources for quite a while. Let me just touch on the concept of death rates that Dr. Costas brought up. So, and he mentioned this, but I will elaborate a little bit. The people that are highest risk are older people, as Dr. Costas mentioned, but it's also people who are smokers, who have a underlying lung disease like COPD, or have a heart disease like heart failure. So, you know, Yaya and Bapu that have these, they're older, they have, you know, you get older, you tend to get these problems. So those are the people we really have to watch out for. Like you said, you want your mom to be safe. We want Yaya and Bapu to be safe. And then they're the ones that tend to go to church every Sunday too.
Yeah. So you mentioned, you hinted at a second wave. I mean, is there a possibility that we may see a second wave of COVID or another strain of this?
So what they're seeing in South Korea is that they had their wave, it came down, but they still have a small but significant number of new cases going on, and they have not been able to eradicate that. They have not been able to squash that completely. So that means that the disease is still in the population. It's still endemic in the population. So we're not really out of the woods once the wave goes down. It's good in one way because we'll be able to focus our resources, and hopefully we'll be able to ramp up testing and do mass testing of populations to see who's sick, who's not sick, who's been sick and can go back to work because they're probably going to have a certain degree of immunity. And I've heard it's been estimated at, you know, anywhere between 6 months and a year. Nobody knows for sure.
Oh boy.
So unfortunately, because the coronavirus is in the endemic and now in the population around the world, we're going to have cases of outbreaks, small outbreaks here and there. So somebody gets on a plane who's sick from Australia, comes to Chicago. He's exposed to a whole bunch of people on that airplane. Those people now, say 10 people get off the plane and they now are infected, but they don't know they're infected. 7 to 10 days later, they're now not just infected, but they're infectious. And now they're in the city of Chicago, and now we can have another outbreak. So it's going to be very important to identify cases early and then identify their contacts and treat those contacts. So hopefully we'll be able to develop an effective, a workable vaccine that we can get out to the population. This is going to have to go around the world because if you have somebody sick in one country, you can vaccinate most of the people in one country, but if somebody's sick in the other country, they could still come here, and the people that didn't get vaccinated could still spread the disease. So it all depends on how strongly and how forcefully we respond to each of these outbreaks to contain them. But we will be getting these small outbreaks until we are able to vaccinate a good chunk of the population.
All right, so we spent some time talking about the biology, the mechanics of the virus and the epidemiology side of things. Now let's talk about kind of day-to-day care and medicine and the need to see our doctors and to get treated by our doctors. Dr. Stein, you know, there are many people who are asking and they're trying to figure out whether or not, you know, what to do now that doctors are calling. I had to see a doctor, my mother had to see a doctor. We've been getting calls and we're told, you know, we can't see you. Would you like to reschedule? And the truth is, I put off rescheduling just because I don't know if I'm going to have to reschedule again my appointment. But what do you recommend them when somebody has an annual checkup, a colonoscopy, a mammogram, or something that you kind of regular testing to make sure preventative care? Should they kind of hold off till next year, or put it off completely, or what do you recommend in those cases?
Yeah, that's a great question. All of us, you know, really need to make sure that our health screening is up to date. So that includes a visit with your physician, and at our institution, and I believe at all institutions across this country, colonoscopies, mammograms, pap smears, they have all been temporarily put on hold. Only if someone has a concerning symptom are they going to be able to get a test. But from just a screening, healthcare, health maintenance standpoint, in order to protect the public and also to protect the healthcare workers, we had to make really difficult decisions. I cannot recall a time in my entire medical career when mammograms have been put on hold. We expect things to probably return in terms of screening in June, in July, probably more likely. I really recommend people, if things have been pushed back, to make sure that they do get things rescheduled. And I would absolutely recommend that people don't say, okay, 2020 was just the really bad year, and I'm going to put things off until 2021. Certainly, if a mammogram can't get done for 6 months, even for 8 months, 9 months, that's okay. I don't think people should be concerned about that, but definitely to have a appointment on the books and to make sure that it's done sometime within this calendar year would be very good. And all the institutions, we all know, how are we possibly going to make up 2-3 months of mammograms? So I think we're going to see a lot of additional appointments made to accommodate for this.
And so what happens? All right, so that's like your regularly scheduled screening. But what happens if someone notices something irregular with their body, or they feel sick, or they see something that's out of the ordinary? I mean, should they hold off until this COVID problem goes away, or what do you recommend? Do they call their doctor and get in there quickly?
Contact your physician. Hopefully you have a good relationship with a physician. If not, now is also the time to make sure you are taking care of yourself, and not just physical health, but also mental health is very important. But absolutely, we are making priorities. If a woman notices a mass in her breast, that mammogram will get prioritized. So we absolutely want to make sure that people don't neglect things that they find, and do contact their physician. And even though appointments are canceled, if there's an urgent need, we are all seeing our patients. I think my days are spent half on the phone with patients, but the other half, because of what I do, I'm seeing patients still in the office.
So are patients still receiving their chemotherapy sessions? Are they still able to go and receive chemotherapy?
Yeah, we've made some, I'd say, really difficult decisions. We actually have a national guideline task force, both our American Society of Clinical Oncology and also our National Comprehensive Network, that put forth guidelines this week specifically addressing these issues. How do we treat someone in the days of COVID? Because a lot of chemotherapy needs to be given on a certain schedule. And we've looked, whenever we're giving chemotherapy, we always want to say, what's the goal? For patients that have earlier diseases and the goals are to cure them, we don't want COVID to push that goal aside. So we're still treating so that we can achieve long-term goals of keeping people well and disease-free, cancer-free. Patients that have more advanced diseases, we're looking to see, can we delay a dose? Can we try to move past this curve, the upslope, or right at the peak, so that we don't expose too many people? We also have immunotherapy, and we're learning how to dose immunotherapy now in COVID. I think the thing with cancer patients is, we mentioned before, people who are over 60, people who are smokers, heart disease, lung disease, they're all at risk, higher risk for complications. Cancer patients also are at higher risk. And anyone who is currently undergoing therapy, I think it's also important to know, what is my risk? How immunosuppressed am I? When did I get my chemotherapy last? And what's the impact that that has? We actually are giving patients booster injections to help boost their immune system. We've always given it, but we've always given it for patients that are at higher risks, depending upon regimens, chemotherapies that we give. We actually were able to get the national societies to give guidelines saying that patients who are not at such high risk should also get those types of immune boosting support, so that if they contract coronavirus in this time that they're getting chemotherapy, we hope that we will be able to get them through and have their immune system supported. Mm. And we are doing all that we can. We are having patients on telemedicine when it's not essential for them to come to the office. We are also, we're low on blood. You probably have heard that in the news. Blood drives that normally routinely happen here in the city weekly, monthly, have been postponed. But we're actually doing blood drives at the hospitals. And a lot of us, the employees, physicians, nurses, the staff are actually donating blood, which is remarkable, so that we can help to maintain our blood supply for patients. For anyone who's living with someone who's getting chemotherapy and wants to know how they can also best support them, make sure that they're isolating, make sure that they're taking their temperature, make sure that they're engaged with how they're feeling and if they're having fevers, and cook food. Make sure people are eating well, and they're definitely following up with their physicians. And reach out to us. We absolutely want to keep the communication going.
Well, thank you for that, Dr. Stein. And maybe at some point we'll get some information about blood drives and where they're offered and how people may be able to go and safely donate blood
yes.
to keep those blood supplies where they should be. So why don't we talk a little bit about our own community, in particular our churches and Holy Week. Dr. Costas, I'm going to turn to you and the Deputy Chief here for a little bit. So the Holy Synod of our church here in America, the Parochial Synod, and actually the Ecumenical Patriarchate for all of the Orthodox churches around the world under the Ecumenical Patriarchate have decided that the best way right now to celebrate services is to continue celebrating behind closed doors with a kind of the priest and a few individuals assisting. Could you both kind of speak to why that's the best way, and if you've heard of some other ideas of maybe how to distribute things? That we've said that we're not allowed to distribute palms, red eggs, holy unction. We will not give Holy Communion to people, and I know how difficult it is for our people to be without these the sacraments and the sacred and blessed objects that we're used to receiving. But can you tell us why that is probably the best way to approach what we're experiencing now? Doctor, you're muted.
I'm unmuted now.
And so is the Deputy Chief. So Steve, you're muted too when your turn is
up. So now you can actually hear what I'm saying. So the issue really is everything that's been said. It's all about the social distancing. And any way you cut it, there's no way you can congregate and maintain real social distancing, especially in the numbers that we're talking about going into Holy Week, things like Palm Sunday, the Holy Unction, Communion. Once you have all these individuals with good intentions, but unfortunately we're also very social beings. Once you put them together in a space, trying to maintain the 6 feet rule, and as the other Dr. Costas, our infectious disease doctor, said, that's just one aspect of it. It's who's to say somebody hasn't coughed or sneezed in an area that you then partake. There's also the aspect of the individual who might be symptom-free that's handing out the palms or the Holy Unction, especially if you're trying to do it in a certain venue. What's to say that they themselves might have the disease and just unknown to them? So they're then transmitting the disease to a very large community that then will go back to their homes and to the grocery store and other venues, and that's where this can spread. So from a situation of what is responsible, as difficult as it is for all the reasons mentioned, that is the crucial aspect, is really trying to maintain this as best we can, so then we can move forward as a society. Steve will obviously talk to I'm sure better than I can about the difficulties. Even, I've heard people say, how about a drive-through? The risk that we put your first responders, how you would maintain the number of cars, what you would do to different venues, and you're still getting a large group of people out. And as I can't remember, somebody else mentioned, maybe it was Dr. Kyriacou, those who will want it the most are the elderly. They're going to be the ones that come out. They're going to be the ones that will demand this and make that effort. And those are the ones that are most vulnerable. So just like the mayor or the governor have kind of put these borders in place, it's to protect ourselves. So what I think your thoughts are, Your Eminence, is to do the same thing. It's to protect us from ourselves. And sometimes we actually need that. So that's where I think the importance would be to follow through. In terms of how many people on an altar, that has been brought up. Holy Week might require additional people, but looking at the spacing of a typical altar to try and maintain the distancing, probably no more than 4 people would probably be the most appropriate number. And hopefully also those who can wear masks if it's feasible for them. Obviously there's probably a couple there that cannot, but once again, it's all about reducing risk. I'll let Steve talk about the
and exactly. I mean, the drive-by to pass out the oil, taking the epitaph outside and walking around. People will say, but we're outside, we're in open air, free air, we're not inside the church. It really doesn't matter. It's creating that 6-foot spacing. And the orders are down from the public safety officials and the public health officials that you can't congregate in groups of more than 10 as well. And that goes for outside. It's not just the inside. And all you're doing is just increasing exposure amongst the community, but also increasing the exposure for those first responders as well. And taking those first responders away from maybe something more important or something more pressing to be able to deal with the issue of the group gathering. So it's going to be hard. It's going to be painful. Trust me, nothing more than knowing that Yaya and Papu are maybe don't fully understand the magnitude of it. But we have to do this, especially for them. There's no doubt about that.
I would say that Steve, that the Yaya and Papudas understand making these types of sacrifices. I mean, they've been used to making these sacrifices for years back in the old country. Sacrificing food for the children, not being able to move freely because of the weather and lack of clothing, and I think it's more of our generation, the younger generation, that kind of is having a hard time with this. And I mean, for those watching us today, we've discussed all of these different options. I mean, we've explored everything from outdoor spacing people, and having lines and people coming up with their cars and receiving it in their car, and the different risks associated with all of these different measures. The best thing for us to do was to just keep it simple and to say we're continuing with the way things have been thus far. I think there are several people in the community. Usually they're the loudest, the ones who insist and demand and will remind everyone that it's their right, that they are being refused their right to receive the Eucharist, that they have a right to go to church. And I remember talking to one of the first responders who said, Your Eminence, these people, if they don't mind putting themselves at risk You know, that's one thing, but now they're transferring the risk onto us. The men and women
Absolutely.
who are in the hospitals, on the streets, patrolling the streets, trying to care for us, they're the ones now who are going to have to deal with our, you know, boldness and cavalier ways. And I would call it selfishness. It's spiritual, you know, selfishness to say that I deserve this. It's mine and let me make the choice. I mean, the doctors and the nurses and the police officers don't have a choice. They're there to serve us. And when we, you know, do things that are careless and reckless, we put their lives at risk. So you know, before we go on, I just want to thank you all. I don't know if I did that in the beginning of our conversation, but every single day, each and every one of you puts yourselves at risk because you care about others, not because you're reckless, but because you care. And so the least we can do is also remember that when we feel the need to say, I want it, to remember that someone else has a family, someone else has children, someone else may be taking care of a loved one, and they have no choice but to care for us. They will not turn us away when we go into the hospital. So let's do the best that we can to keep them safe as well. Dr. Chiampas, speaking of the hospital, I mean, you said you're in emergency care, emergency medicine. What exactly are you seeing in the emergency rooms? I mean, I've stayed away from the hospitals. There's no need for me to go, but I just can only imagine what's going on. Tell us a little bit about what's happening there.
Yeah, so myself and Dr. Kyriacou obviously work together in the emergency room at Northwestern. It's a large urban academic medical center. You know, there's something to be said about that this is unprecedented. There's something to be said about that this is something we know little about. And we're seeing things for the first time in our careers. We're seeing, you know, healthy individuals that are coming in short of breath. They can't find oxygen for themselves. Their oxygen levels are in numbers that we've rarely seen. Individuals that the only way that we can support them is by machine. Then we're seeing individuals that Dr. Stein has taken care of for years that have done everything for 15, 20 years, are still immunosuppressed, but unfortunately were exposed to someone 20 days ago and now are facing death. We're seeing individuals from nursing homes who are dying by themselves. We're having conversations, moral and ethical conversations about who could potentially get a ventilator and who wouldn't. We're having conversations with police officers and firemen about protocols about them entering homes, and if someone is near death, to not offer extraordinary measures because of the massive risk to them and potentially the future attempts of saving that individual's life. These are things that we've never faced before, to be perfectly honest with you. These are things, you know, while we talk about high-risk individuals, we also had a police officer and a firefighter in the city of Chicago that both passed away. We have individuals that, you know, drive trains that allow people to get to work, to the grocery stores, that are getting infected. So there's something also about a viral load that we're all also recognizing. That viral load is, for example, when we go into a room and have to put someone on a machine, we're in there for 45 minutes on a procedure that sometimes when we have trauma patients or urgently can take us 5 minutes for us to put a tube to save their life. We're taking 30 to 45 minutes in the room so that we could protect the nurses, the respiratory therapists, the doctors, the residents that are in the room, and we're extremely meticulous so that we can protect ourselves and do this in a way not to spread the disease. At the same time, we're having multiple other patients coming in requiring the same thing. So in the emergency department right now, because of the stay-at-home measures, it is without question allowing us to really focus on these patients. We're seeing probably 70 to 80% of the patients in the emergency department are COVID. And that has been extremely helpful that we're able to concentrate on COVID and not have the car accidents, the everyday things with when people come into the city, are out and about. Otherwise, it would absolutely overwhelm our system. It would shut our system down and there's no way we'd be able to manage it.
Wow. I mean, no one, I don't think I ever thought of, what you would have been experiencing if those other kind of traumas were happening at the same time. These stay-at-home orders are meant not only to reduce the risk of the transmission of the disease, I suppose it's also to reduce these other types of accidents and injuries that would, like, as you said, overload the system. Some of our clergy have visited patients in hospitals, and the protocol for visiting a patient for pastoral reasons has changed, and we have to get advanced clearance from the hospital. The priest has gone in, they fully scrub him down and wear all the protective gear that he has to. Even when not visiting a COVID patient, we're not allowed to visit COVID patients, even as clergy, even as they're dying, we're not allowed to. We had one instance where a priest, and it was in the article in the Tribune recently, one of our priests was called, one of the parishioners was dying, very close to the end, and the hospital called, and I think that one of the nurses or caretakers went in with the phone and put the phone by the ear of the patient, and the priest was able to just offer whatever, if he prayed for the person or offered some sort of words of comfort at that moment, and the person shortly thereafter died. So we also are seeing ourselves do things that we never thought. We weren't trained to do this. We were never trained to think in these terms as a priest. We think of, like, this is how we care for people under normal circumstances.
Yeah, I think that part of our process is sadly before we put a tube to protect them, Your Eminence, is to try to give them a few minutes to potentially say goodbye. We are cognizant that if you're put on a ventilator, your chances of not surviving are fairly significant. And so during that period of time, for our staff, it's an extremely emotional time. It's us trying to find an iPad, a phone, to have them potentially say their last goodbye. And I would say that everyone on this needs that spiritual health. We go to church, we seek it out as well, but we also, as physicians, as law enforcement, we recognize that there's a threshold. And we're past that threshold. No one wants to make decisions that don't allow individuals to have the opportunities and the things that are essential to them. But all of us here also, we've had to change how we work. We've had to change our personal lives, our professional lives, no different from anyone else. But it's about all of us right now. It's not about any single individual. It's not about any single want. We're in a crisis. There's a reason why it's called a crisis. And we are all going to have to put efforts in not only protecting law enforcement, those at the grocery stores, those that allow us to be able to have some semblance of normalcy while being in our homes, but recognize that there's a risk that's taking place. And there's plenty of people that we're seeing on TV that are being succumbed by this. So we can't lose sight of that. When we're looking at 800 people dying in New York in a single day, or 1,000 a single day in Spain, there's definitely a seriousness about this. And we're seeing it every day in the emergency department. We're seeing it on the streets, but the stay in shelter is extremely helpful right now. And I think that's the difference maker.
Your Eminence, I'd like to add a couple extra notes. It's not all bad news. It is serious, and it's sometimes there's a lot of despair. But looking at the future, there are some pharmaceutical companies that are developing potentially effective medications for those that are on the ventilator, and also medications for people who just get like a mild case or a moderate case of COVID. There's one company that is led by a Greek American who is and they are working on laboratory derived or laboratory made antibodies to the coronavirus. So there is some hope in the future, and also there are a lot of teams working on developing a vaccine that will hopefully be useful and effective.
That's good to know. Thank you, Jim. I want to thank everyone again for their expertise, their time, for lending their expertise and their time today. I will say that I hear in each of you a sense of urgency, and I can hear the adrenaline. And I think we're all on alert during these times. And I will just say that the church is here for you as well. I find myself exhausted emotionally and spiritually. I was speaking with my own priests, and I told them it's okay if you're tired, or if it's okay if you're scared. It's okay, you know, if you need a break. And at times I feel that way as well. And I just want you to know that I'm here for you. If there's anything I can do for you, or you need someone to talk to, we can find someone for you. If you need a prayer or a blessing read over you, we can find a way to do that, even with social distancing 6 feet away. But sometimes, you know, the people that we're speaking to, either through Zoom or Skype or even face-to-face, it tends to be around the coronavirus. It tends to be around the crisis that you were dealing with. And it's not enough, I think, I don't think we have too much interaction with people that's different than that. And I think we need that. So if there's anything that I could offer to you all, never hesitate to ask. I thank you for assisting the Metropolis, for guiding us along the way. You've helped me make some very difficult decisions over the last few weeks, and I've made those decisions based on your expertise and that of others, and based on what I feel is good for our people. I wish you all Kali Anastasi, since we are going to begin Holy Week next week. If you have friends or loved ones who are celebrating it this week, I wish them a blessed Easter. And I look forward to the day when we can get together and embrace one another and see each other in church.
Thank you, Your Eminence.
Thank you.
Thank
Have
you.
a beautiful evening.
Kali Anastas. Thank you.
Kali Anastas.